Now, most children with asthma respond well to inhaled corticosteroids or medicines given through inhaler. But it is seen throughout the world that approximately 5% of patients may not improve with the first line treatment. Now, if children do not improve with inhaled corticosteroids, with some more medicines like long-acting beta agonist, like formoterol or salmeterol, then they are labeled as difficult to treat asthma. Now, how do we approach a child, or how do we manage a child who has difficult to treat asthma? Certain things have to be taken care of. One, that is the diagnosis correct? Is it actually asthma or some other diagnosis which we have missed? So there are patients who have cystic fibrosis, ciliary dyskinesias, problems of reflux, problems like bronchiolitis obliterans, and some other problems which might be congenital, for example, a tracheomalacia, which might be mimicking an asthma. The other thing which we need to look at is the comorbid conditions or allergic problems which are accompanying asthma. So we look at the nasal allergies or allergic rhinitis, sinusitis, eye allergies, reflux problems, and sleep apnea. So comorbid conditions need to be properly seen whenever we are trying to manage a child with difficult to treat asthma. The third thing which we would always see is the environment of the child. Have we actually taken care of the allergens which might be there in the environment, which might be like dust mite, which might be like animal dander, which might be molds, cockroaches, and other triggers, for example, cigarette smoke, smoke from agarbattis, dhoopbatti, mosquito coils. Some families in the villages also use kerosene or wood for cooking, and that can be a very important allergen. The next thing which we would like to see is the technique with which the medicine is given, and in most patients it is found that the technique which they are using for using the inhalers is incorrect. Many a times children are not using their spacers, or the way they are using it is actually inappropriate. The adherence to medicine also needs to be checked, whether they are actually taking their medicines properly or not. Now, children with difficult to treat asthma require some basic investigations, which are usually in the form of a pulmonary function test like a spirometry and a musculometry. They also require some allergy testing, which might be in the form of a skin prick test or an immunogap, and sometimes they require exhaled nitric oxide, or also known as the phenol. If needed, especially if we are considering alternate diagnosis, then they might require additional tests, which might include a CT scan of the chest, might include a bronchoscopy, might include some genetic testing and a sweat chloride test. But these may not be required in most patients. Now, how do we treat a child who has difficult to treat asthma? So initially we try and put them on their inhaler, which includes an inhaled corticosteroid, a long-acting beta agonist as we talked about. We usually add something known as tiotropium, which is a long-acting muscarinic antagonist. We try and treat the comorbid conditions, and we do that for the next 3 to 6 months. We take care of the home environment as well. Now, most children will be doing well with this treatment regime, but there would be an occasional child who would not improve. In these situations, some more medicines needs to be used. These are newer medicines which are known as biologicals, and the most commonly used medicine is omalizumab, which is a 90 IgE medicine. There are other biologicals which are now available for children, which includes mepolizumab and dupilumab. So in case your child is having a difficult to treat asthma, his asthma is not improving symptoms are not well controlled, do get in touch with a pediatric pulmonologist for a proper evaluation